Welcome, welcome. I'm going to try and teach you about some ECGs. I very much hope that as part of this presentation, you'll feel some of the joy and love that I feel for ECGs. It would be great to share some of that around because I think ECG is such a wonderful, simple investigation. So I'm hoping that I'm going to take you from this. Can you imagine a screwed up ECG in this gentleman's fist through to the promised land of blissful synergy with ECGs that this very impressive doctor has achieved. And we're obviously going to talk about P waves, about QRSs, and about T waves. And I'm sure you're all very familiar with the basics of the ECG segments. I'm hoping by the end of this, you don't have a non-physiological tattoo like this, and that you find this tattoo quite offensive. And I'm going to cover bradyarrhythmias and narrow complex tachycardias and broad complex tachycardias. Please ask questions as you go along. Please put things in the chat if you've got any issues, questions you want to raise as we go along, or if you want to unmute yourself and ask the question, you're very, very welcome to. So without further ado, let's start with some bradyarrhythmias. So I very much want this to be interactive so that we can talk through the ECGs and you can give suggestions as to the diagnoses as we go along. So would anybody like to suggest what is wrong with this ECG? So if you just put in the chat, what's the diagnosis on this ECG? So when you're asked about an ECG, the first thing to check is the patient's name. Excellent. So we've got first degree heart block coming through in the answers. So check the patient's name, date of birth, check the date of the ECG, and then start looking at basic things like the PR interval. Now, PR interval should be measured from the start of the P wave to the start of the QRS. And the P wave starts in whichever lead it starts the earliest in, and the QRS starts in whatever lead it starts earliest in. Mostly that's not an issue, but you can really pick any lead you like here. Can you see this is a very, very long PR interval? Now that wouldn't require, technically speaking, any great concern, but when the PR interval's getting as long as this, you start to worry about, are they having higher degrees of block at other times? So this sort of a patient I'd want to do a heart monitor on. I would, if they were an inpatient, if they had fevers, might think about things like endocarditis that might be affecting the PR interval. So pronounced first degree heart block like this does require a bit further investigation. If it's just over 200 milliseconds, that's not something I would look into in itself without any symptoms. Good, so nice and simple. What about this one? What does this ECG show? So having looked at for our P waves and our PR intervals, we're then going to have a look next at the QRS. And what do you all think of the QRS complexes here? Are they normal in duration? Good, so they're broad complex. So we have broad QRS complexes, and therefore it can be either right or left bundle branch block. So we've got Rebecca has said this is right bundle branch block. Does anybody disagree with her? Everybody happy with that? It is indeed right bundle branch block. So the very easy, simple way of knowing is it right or left bundle branch block is just to look at it and say, is there mainly R wave or is it mainly S going down? And if there's mainly R wave, it is right bundle branch block, R for right. It's useful if you can be aware of the morphology of bundle branch block, because when we get onto the tachyarrhythmias, diagnosing them, it becomes important to be able to say if it's typical or atypical right or left bundle branch block. So let's just have a look at what typical right bundle branch block should look like. And this is a diagram of it. You can see that this pretty closely matches V1. What we're looking for is this little r, S, big R, RSR pattern with a lopsided rabbit ears. People often talk about them. So this one should be smaller than the second one. And then in the lead V6, so we look at V1 and V6, we should have possibly a very small initial Q wave and an R wave, large R wave, followed by an S wave. And what word do you use to remember right bundle branch block? I'm sure you'll all come out with marrow. And that's the idea that you can draw an M here, and that looks like an M, and I can just about buy that. Then this looks like a W. I struggle with that. So I'd suggest to you that a better word is actually Morris. So you have the M that everybody's happy with, but you have an S wave here. So think about Morris or marrow if you can squint a bit and convince yourself that's a W. Good. So this patient has right bundle branch block. Is there anything else we can say about this ECG? Or is right bundle branch block the only diagnosis to be made? So having looked at the QRSs, the QRS complexes, the next thing along is to have a look at the axis. So is this a normal axis or not? What do I mean by is it a normal axis or not? Does anybody want to say, is this normal axis, left axis, or right axis deviation? Left axis deviation, very good, Will. So it's important to be aware that the ECG is looking at the heart from a number of different directions. And I like to wave my arms in the air, which you won't get so well when we're not meeting in person, but I like to hold my arms up like this up in the air. If you do that and embarrass yourself a bit, it's always good to embarrass yourself a bit when you're trying to learn something because people remember being embarrassed. Your right arm is looking like AVR at the heart. So AVR is looking up to the right and AVL is looking up to the left. And if you've got those two in place, you then just need to go down from AVL. Horizontal is 1, then we have 2, AVF, and 3. And you can immediately see from this that these leads are looking at the heart inferiorly from underneath. AVL and 1 are looking at it laterally from the side. And AVR is over off on its own, completely the opposite direction. Now, the electrical impulse tends to start in the AV node and it then flows through the heart. So it flows away from AVR. So AVR should usually be negative. And it should usually be predominantly positive in lead 2, or maybe 1, or maybe AVF, that sort of area. If it's not, if it's negative, that's because the axis is moving predominantly in a different direction. And if it might be more up here, or it might be more down there. Now, the precordial leads, we don't use them for axis because they are separate entirely from this. They're sort of dotted over the chest and they look over the anterior wall and some of the lateral wall. So we don't look at those at all for looking at the axis. But if we come over here, the simple way of remembering it, the sort of ideal option is to say which lead is it most, the most R wave in, and find a lead that's isoelectric to that. And from those you can come up with a precise axis, but more than good enough for your purposes is, I apologize for the bar, Windows bar, that's irritating that that's not gone away. It's supposed to be hidden. So if it's predominantly up in leads 1 and 3, then that is definitely a normal axis. You can relax. And I would actually more usefully than that is if it's not right or left axis deviation, you can just call it a normal axis. Right axis deviation, if it's negative in one, that is right axis deviation unless it's also negative in all of them. So predominantly, if it's completely negative in one, that's right axis deviation. Left axis deviation is if it's negative in 2 and 3. So here, can you see it's negative in 2 and 3? In fact, it's starting to go negative in 1 because this is pronounced left axis deviation because it's pointing right the way around here. So this patient has right bundle branch block and left axis deviation. And what's that give him as a diagnosis? Does anybody tell me what the combination of left axis deviation, bifascicular block? Thank you very much. So we have bifascicular block. Does that need a pacemaker? Joseph wants me to explain that again. So bifascicular block means a combination of having right bundle branch block and having left axis deviation. And I will explain that more in just a second. So this is bifascicular block, and this again might make me think, do I want to do a 24-hour ECG in somebody who's fit, even if they're fairly asymptomatic, because maybe they'll have a heart block and we could diagnose something before they fall over and break their hip, but it doesn't require pacing. If they had typical cardiac syncope and bifascicular block, that's enough for us to put in a pacemaker without needing to look further. Great, so welcome anybody who's just joined us. We are recording this, so please, if you have any concerns about being recorded, just let me know. So then moving on, I'll show you one more ECG and then I'll explain about this trifascicular bifascicular block in a little bit more detail. So what does this ECG show? Trifascicular block, yes, it slipped out. So this again shows right bundle branch block. Can you see we've got our lopsided rabbit ears, our RSR pattern in V1, and we've got a little Q wave in V6 with our S wave. So this is absolutely classic right bundle branch block. We also are predominantly negative in 2 and 3, much easier to see actually than the previous ECG because it's less isoelectric, and the signal is predominantly pointing towards AVL. So this is left axis deviation. Can you see it's most positive in AVL? So that's the direction it's most pointing in. So this is left axis deviation, and we have first degree heart block measured from the start of the P wave to the start of the QRS. That's more than 5 little squares. It's more than 200 milliseconds. So that's trifascicular block. Does trifascicular heart block require a pacemaker? So we manage trifascicular block just as we would bifascicular block. It might make us want to look to see if there was something more, but it doesn't in itself require a pacemaker. So what on earth am I going on about with this bifascicular, trifascicular block? We have got, does anybody know how to get rid of your, it's disappeared. That's what I wanted to do. So if you look at the anatomy of the heart, we've got here the right atrium, left ventricle, right ventricle. You normally have the electrical signal coming from the sinoatrial node. It then goes to the AV node, down the bundle of His, and then it goes into this splits into the right and left bundles. Now, the ventricle, the heart, is all about the left ventricle. It's got about 90% the muscle mass in the left ventricle. So there's much more electrical supply going on here because there's more muscle to get the electricity to. And you have 2 different fascicles. So we talk about those being 3 fascicles, and we talk about the left as being the posterior and anterior fascicle, and then the right bundle branch is also counted as a fascicle. So we ought to really call it the right fascicle, but we call it the right bundle. So that's where the 3 fascicles come from. And that means that trifascicular block is a misnomer, because if we block the left posterior fascicle, the left anterior fascicle, and the right bundle, what would we have? What would be the name of the heart rhythm that really is block of all 3 fascicles? Yes, complete heart block. So clearly trifascicular block isn't at all complete heart block. Trifascicular block refers to disease in 2 of the fascicles. So if you've got left bundle branch block, that is technically bifascicular block. We don't call it that because it's left bundle branch block, but it's basically the same thing, managed the same way. So either we have block of the right bundle branch and the left anterior fascicle, or more rarely the left posterior fascicle, or we have those 2 plus we have disease in either the AV node or the bundle of His. You don't know with first degree heart block where the disease is, but it's somewhere here, and depending upon where it is, can affect the risk of you progressing to a pacemaker. Not that we investigate that routinely, but you can do EP studies to explore that. So if you've got a first degree heart block, that suggests there's also disease going on here, and we presume therefore there's disease in the 3rd fascicle, and we call it trifascicular block. So that's where this trifascicular block, bifascicular block comes from. Everybody clear on that? Good. So what about this ECG now that you're experts in fascicular block? Can you tell me, is this left or right bundle branch block? So Will has said right bundle branch block. So I've had a request to explain some of that again. Could I could just do with a little bit more specific which bit. I mean, I'm recording this, so you'll be able to listen to that back again. And if you want to ask me questions in emails, I probably, rather than going over the whole of that again. So I've got now, Chris has said left bundle branch block. So if you look in V2, this is very clearly a W, isn't it? So, we can't see our M over here, but we never can see the M over here. So this must be left bundle branch block. Does everybody else agree that Will is wrong? He's got a few questions right, but maybe he's just reached the limits of his knowledge. Does anybody want to wade in with the answer, or just tell me to stop being mean? So the answer here, yes, very good, Anna. There is an M in V1. So this is really confusing, isn't it? Because it's left and right bundle branch block. And the answer is that this is a wonderful ECG because it will tie everybody up in knots, including people who are quite experienced in cardiology, because it's rare. This is right bundle branch block, but can you see the axis deviation? So we've got marked right axis deviation here. It's negative in V1. So this is trifascicular heart block with left posterior fascicular block. So we've got block of the right bundle, we've got block of the left posterior fascicle, and we have first degree heart block. So don't worry too much about that, because that's a very unusual thing. You won't see it, but if you do, you can be delighted. But it looks a bit weird, and the reason I throw it in is just to help you think about your bundle branch block patterns and to show you an example of profound right axis deviation. Look, it's positive in AVR. It's pointing in completely the wrong direction. Great. So moving on, we've covered the different types of fascicular block. What am I gunning for next? What do you think this ECG shows? So I've got a second degree AV block volunteered. It's a good start. A good start. Does anybody else agree with that? So Rizwan is also saying second degree AV block. So can anybody expand on that? So Jenny said Mobitz type 2. So that's another very good thought. And another person is suggesting Mobitz type 2. Now Will has said Mobitz type 1. So what you need to do here is mark out the QRS complexes and mark out the P waves. So if we mark out our P waves, you can see them all really nice and clear in this ECG. Can you see that they're regular? And the fact that they're regular means that, you know, obviously we're in a sinus rhythm. We're not seeing any atrial ectopics. So that's a very helpful start. And then if we mark out our QRS complexes, can you see that they're also regular, but they come in clusters of 3 with a gap in the middle. And can you then look at the relationship between the P waves and the QRS complex and see how that starts out short, gets fractionally longer again, and then it misses. And then that relationship is reset. So with it marked out, can everybody agree with me that this is Mobitz type 1 heart block? So this is Wenckebach or Mobitz type 1. And this, in all your exam questions, doesn't need a pacemaker. But the reality is that if an elderly person is doing this at rest, they've probably got something wrong with their conduction system causing it. If a young person's doing this a bit at night, then they've just got high vagal tone and it's a natural phenomenon. So Wenckebach at night in a young person, nothing to worry about. If you're in your surgical pre-admissions and you pull off this ECG, they're pretty bradycardic. They've got Wenckebach at rest. Maybe there's something that needs pacing here. So this certainly should merit some further investigations. So does that make sense to everyone? Mobitz type 1 or Wenckebach it's a hard one to diagnose. It's often missed and it's often confused with Mobitz type 2, just as it has been here, because you see that 2-to-1 heart block, it's harder to see the PR intervals extending. The clue to it tends to be that you have this irregular ventricular rhythm. Normally speaking, in 2-to-1 heart block, you'll see a regular but slow QRS complex. And 2 P waves before each one. Here, the ventricular complexes are coming regularly, but with gaps in them. So what about this ECG? So Mobitz type 2 has been suggested. So does everybody agree with that, or just looking here, can you not see P wave, QRS, T wave, P wave, QRS, T wave, P wave, QRS, T wave? Is this not just left bundle branch block and sinus bradycardia? So, Dr. Al, are you still going to stick to your guns and go Mobitz type 2, or there are missed QRSs? So can you see 2 P waves for each QRS? Where are they? I can see a P wave. I can't see a P wave. I just see a nice T wave here, maybe slightly long QT interval. So I can just see one. I can just see sinus bradycardia. So left bundle branch block. Very good. The V leads and the T waves and the P lead waves are overlapping exactly. So I'll come to that in 1 second. Just to stick with what does left bundle branch look like. So we've talked about it being predominantly negative, and therefore it doesn't have an R wave mainly. So if it's mainly R, it's right. If it's mainly down, it's left. We tend to see a V shape. This, can you see it's fractionated here? So it's almost a W. That's why it's William, but it's rare to see that. And similarly, this M shape here, this, you can almost see the fractionation here. That's rare. You usually get an R wave and an S wave. So William, I find I just can't see this as a W. So I think Victor is better. V in V1, R wave in V6. But you know, however you want to remember it. So that's left bundle branch block and typical left bundle branch block. So again, mark out your P waves, and you're very good in spotting that the P waves are there in V1. You could ask for V1 to be your rhythm strip, but usually you see the P waves best in lead 2. Here, actually, you do see the P waves very nicely in lead 2. The problem is you're not sure if this is P wave or T wave. Now, once you've marked out your P waves and marked out your QRSs, you immediately see that there are going to be 2 P waves for each QRS, and this is therefore 2-to-1 heart block. And also, remember, these leads are recorded simultaneously. So if you shade down what is the P wave and look down here, you can see, in fact, that the T wave here is pretty isoelectric, which you might expect it to be given how isoelectric the QRS is. Isoelectric means you just don't see very much of the electricity because it's going sideways as opposed to towards or away from that lead. So you actually see the P waves very nicely. So what I was calling a T wave here is actually a P wave. So you immediately see very clearly this is 2-to-1 heart block. Now, a useful trick if you weren't sure is to have a look on the monitor at different heart rates, and sometimes as the heart rate varies, the P wave might emerge and merge with the T wave. So it can be useful to look at variations in the heart rate. If the heart rate doesn't vary at all, that also points towards them being in heart block. So often if you go and talk to the patient, you'll work them up a bit, increase their atrial rate, and you can then have a look at what happens to the P waves as you're doing that. Obviously, you're not deliberately trying to upset your patients. So Mobitz type 2 heart block and left bundle branch block. And by process of elimination, what have we got here? Complete heart block, very good. So again, mark out your ECG complexes, and you can start off by marking out your QRSs and see that they are regular. Complete heart block should be regular. It would be very unusual for it to be irregular. So looking for regular QRS complexes, and mark out your P waves. Very often you can't see all of the P waves, so mark out a few and then ratchet your piece of paper along the ECG and discover that here is a P wave buried in a QRS, just where you would expect it to be. And that little hump that you weren't quite sure if it was something or not is clearly now a P wave. Bit odd that you can't see one here in this nice flat section, but you just have to accept that, you know, the ECGs are not always wonderfully clear. So this does look similar, Joseph, to 2-to-1 heart block, but it looks similar in the QRS being regular and slow. What is completely different is this total lack of relationship. Can you see now I've marked this out? There is no relationship between the green arrows and the red arrows. Whereas if we go back to the 2-to-1 heart block, there's this very precise relationship. Green, red, green, green, red. Green, green, red. And you see that there would be a P wave here and a P wave here. So 2 greens to each red, 2-to-1 heart block. If there were 3 greens to 1 red, that would be 3-to-1 heart block, but it would still be Mobitz type 2. Often when patients are in complete heart block or 2-to-1 heart block, their body's sensible. It recognizes that the heart isn't going very fast and it says speed up. So often they tachycardic in their atrium. Can you see this atrial rate here is about 100? So they're trying to make their ventricle go faster because they know that it needs to, but obviously they can't. So this is complete heart block. And this always requires pacing, just as did Mobitz type 2. If you saw a bit of complete heart block on a 24-hour ECG, they need an admission and they need pacing because they're at risk of asystole. If they've got a little bit of Mobitz type 2 on a 24-hour ECG, they still definitely need pacing, but you might bring them in as an urgent outpatient. If they have it on a ECG that you're doing in surgical pre-admissions or for another reason, and they're in 2-to-1 heart block like that, the previous one, I would want to admit that patient because I would be worried that if they're doing this all the time, that you'd pick it up by random. They're probably in higher degrees of heart block at other times and are again at risk. So a little bit on a 24-hour ECG, by which I mean a couple of beats. You really need to have two, or maybe at least two examples of the 2-to-1 heart block. Otherwise, you might just call it a dropped P wave. To call it 2-to-1 heart block. But if you see that on a 24-hour ECG, that would need a pacemaker, but it wouldn't need an admission. If they're in it all the time, it does. So what about this ECG? Can everybody see? There's a nice little P wave here. Can you work me out what's going on with this ECG with the help of a P wave spotted? Does everybody agree with me that this is a P wave? Looks nicely formed. You can see it in this lead and this lead and this lead. Can't see it so well here. So Rizwan has said paced rhythm. No, this is not paced. Good thought, but no. With paced rhythms, you often can see a little pacing spike. Not always. LVH, yes, there's left ventricular hypertrophy on this ECG. Dr. Al has suggested Mobitz type 2, so it's a good thought. I mean, the rate would fit with Mobitz type 2, but tell me about the P waves. Can you see two P waves? Is there another P wave over here? Are you seeing two P waves to the QRS? Do you agree with me this is a P wave? So I'm trying to persuade you of something which is not the case, and that's very naughty. I do apologize. So you might say this is a P wave, you might say that is a P wave, but can you see the morphology of these is just about the same, but it's not really the same when you look in the other leads. And the P wave morphology ought to be the same beat to beat. It's not always in sick sinus syndrome, but that's at least you'd be seeing clear P waves. What you're seeing here is an irregular baseline. And the rest of the ECG, you can't see anything that looks like a P wave at all. So this is just the irregular baseline, and this is atrial fibrillation. So is everybody happy that we've got LVH and atrial fibrillation and it's just slow AF? I'm expecting a choruses of, yes, this is slow AF. So I'm being asked, is that a P wave after the T in the V lead? So is this a P wave? No, that's a U wave. So that's part of the QRS. So this is atrial fibrillation because you've got this irregular baseline. Can you see that there are no visible P waves and you've got an irregular baseline? There is left bundle branch block, very good. So does anybody want to hazard another diagnosis? Because there's a little bit more to this than just slow AF. How does it show left ventricular hypertrophy? So as soon as your ECG complexes are invading their neighbors, there is LVH present, and you can see this is invading nearest neighbor. There are 1,000 different ways of quantifying LVH on a 12-lead ECG, and all of them get defeated by patient's habitus being challenging. But here you've got some very deep S waves. So this is LVH. So what I want you to shout out to me is, look how regular this is. Look how regular this is. So how is it that it's regular and this patient is in atrial fibrillation? This is complete heart block. Very good. So atrial fibrillation, chaos of noise going on in the atrium, will never give rise to a regular ventricular signal if the ventricle is listening to that chaos. Therefore, we must have complete heart block and the ventricle isn't listening to the atrium. Can anybody tell me what the heart rate here is? So I've given you a terrible ECG without the squares on it to allow you to count, but does anybody know another way of assessing the heart rate? So a 12-lead ECG, you can see from the calibration signal that this is normal calibration, with this being 1 centimeter wide. That, very good, 42. So count the number of complexes, multiply by 6, because this is 10 seconds of recording. So 7 complexes times 6, 42. And as soon as your heart rate goes below about 45, you should be really looking for complete heart block. And complete heart block, you can even have it at rates below 50, but usually below 45. So this is complete heart block and atrial fibrillation because it's regular. And this needs a hospital admission. You can't reduce the rate limiting medication. That's not enough because they could have asystole at any time. So they need to be admitted. If they're on bisoprolol and diltiazem, you could stop them and see if their rate improves, but you'd have a low threshold for pacing somebody with this ECG. Excellent. So important ECG not to miss. So that's the bradyarrhythmias covered. I'm now going to move on and talk about some narrow complex tachycardias. And obviously, I'm not exhaustively covering all ECGs possible here, but we talk about them in the other talks that I'll be doing over the course of your time with us. So this is an example of atrial fibrillation. I hope that everybody is happy that there is an irregular baseline. There are things over here, for example, that you might say, oh, those look like P waves, but you can see that they aren't occurring regularly. So these are just the coarse atrial fibrillation is sometimes looking a little bit like a P wave. Equally, you might say, is this atrial flutter when you see this over here? But atrial flutter waves look very, very regular. I think I've got one to show you later on, or if not, I've got one in the AF presentation I'll do for you at some point. So this is atrial fibrillation with an irregular rhythm. And the way to spot that is to mark it out. So does everybody agree that this is irregular? And you're looking for more than about a 25% difference between the longest and the shortest RR intervals. So that's rate-controlled atrial fibrillation. We move our piece of paper along, we can immediately see that it doesn't line up, that this is irregular. So what about this one? Do you think this is atrial fibrillation, or do you think this is a sinus tachycardia? So don't all shout at once. Everybody thinks this is irregular, or does anybody think this is regular? So we've got Al is suggesting fast AF. Anybody think this is regular? So it's unlikely to be AF. If it's regular. Look how regular this is. Yeah, Rebecca, you think it's regular. I'm glad I convinced somebody. Does everybody else have an opinion? Anna thinks it's quite regular. Yeah. So it does look quite regular. But if you mark it out over here, can you see that actually there is comfortably 25% difference between the longest R interval and the shortest R interval? And if we move those along, you can see they don't remotely match up. And this is where it becomes so useful to mark out ECGs in deciding is it AF or not. So if it was sinus rhythm, it ought to match up. Now you can have something called sinus arrhythmia, which is basically as you breathe in and out, your heart rate speeds up and slows down slightly. But here you can see that there is no relationship here. They're long and short intervals and they're not occurring in a pattern. They're not a cluster of shorter ones, a cluster of longer ones that you'd see in sinus arrhythmia. So this is fast atrial fibrillation. What about this ECG? Now, I think I showed this one last week, so I'm sure everybody was listening. So this is a narrow complex tachycardia. Can anybody tell me the heart rate of this, roughly? $150, very good. So you can see that they're just slightly over 2 large squares. So 300 divided by 2 is 150. It's slightly over, so the rate's probably about 145 here. So very good. So here, can you see that there is a little dip after each QRS? And that is probably a retrograde P wave. That is an inverted P wave. So this is probably an AVNRT. And I'll show you what that, how that works in just a second. But the fact that you can see the inverted P wave makes this probably an AVNRT. But the diagnosis here is this is a narrow complex tachycardia. It's not atrial fibrillation because it's regular. It's unlikely to be atrial flutter because while if this little dip was over here as well, you might buy atrial flutter and 2-to-1 block. The rate isn't quite 150, it's slightly longer than that. And you can clearly see a flat segment here that would have a flutter wave in it if this was atrial flutter. And that basically leaves us either with a sinus tachycardia, be a long PR interval for somebody who's tachycardic. As you go faster, your PR interval shortens, so it's unlikely to be a sinus tachycardia. And because we can probably see an inverted P wave, we can diagnose our AVNRT. The alternative would be an AVRT. Now, let me be more precise about what I mean in a second. So this, I'm proposing an atrioventricular nodal reentry tachycardia. And if we go back to our electrical conduction system, what we mean is that our tachycardia is originating in our AV node. What happens is that you have in people capable of having this, you have to have 2 different pathways in your AV node, a fast one and a slow one. And normally speaking, the fast one is active. Now, more than that, the fast pathway has to be like the tortoise, like the hare. It has to be very fast, but it needs a breather. It takes a long time to recover. Whereas the slow pathway has to be like the tortoise. It has to be able to trundle along and always ready to go. If the fast pathway is capable of always going, then you aren't capable of having an AVNRT. You have to have these specific properties for the fast and slow pathway. And probably about a quarter of people do. Not many of them go on to have AVNRTs, but this is why it's so important to be able to induce the rhythm during an ablation so you don't end up burning somebody's AV node unnecessarily, because there's a risk of them needing a pacemaker when you do it. So when you have a premature atrial stimulus, and we all get atrial ectopics every now and again, the fast pathway is lazy. It's having to have a breather. So instead, the slow pathway gets to have its day and it trundles around, stimulates the ventricle. But by the time it's trundled around, the fast pathway is ready to go again because it's had plenty of time to recover. And electrical signals will go in both directions, just like an electrical wire can work in 2 directions. The heart atypics can work in two directions. So the fast pathway is stimulated, and then you go round and round and round because the slow pathway gets stimulated again. It trundles round, stimulates the fast pathway. And each time you go round, you stimulate the ventricle and the atrium. And because it conducts round fast, that means that you have stimulated the ventricle, fast pathway whizzes around, you stimulate the atrium. So the P waves often occur just after the QRS. You don't always see them. They might be buried in the QRS, they might be buried in the T wave. But if you do, that strongly points towards an AVNRT. The alternative is an atrioventricular reentry tachycardia. And this is where you have an extra electrical conduction somewhere other than the AV node, most often the left side, but it can be over the right side, it can be close to the AV node, can be anywhere. You can have multiple. And what happens here is that you conduct through the AV node, back up through the accessory pathway into the atrium, and then back down through the AV node again, forming a circuit. And here, can you see how much more has to be done to get the signal to the atrium? So the P waves typically are buried in the T wave where you can't see them. So if you can't see something like this retrograde P wave, you'd be thinking more of an AVNRT, sorry, AVRT, but it's not absolute. So what does this ECG show on the subject of AVRTs? A short PR interval, very good. So there's a short PR interval here, and any advance on short PR interval? So looking particularly in leads V4, V5, V6. You can also see it quite well in lead 1. Very good. So delta waves. So can you see this slurred onset of the QRS? So can you see how short, tiny, very, very short indeed this PR interval is, and how this is the peak of the QRS, how slurred the onset is, how gradually the QRS is stimulated. And this is because it's conducting both through the AV node and through the accessory pathway. Now, the accessory pathways can only conduct in one direction sometimes, so you don't always see them, and it might be intermittent. So sometimes you see it, sometimes you don't. So mostly in Wolff, Parkinson, White, you have a normal ECG, or in patients with AVRTs, you have normal ECGs. But when you see a delta wave, you can call it Wolff, Parkinson, White. And this is just a diagram to show you this is the delta wave that shouldn't be there. We should have a much more abrupt QRS onset. And you can have all sorts of different appearances of this depending upon where the accessory pathway is. And we'll probably have some fun with those ECGs at some point during your time with us. So this is another example of a narrow complex tachycardia. And I want you to tell me that this is regular. I won't mark it out for you, but I'm sure you looking at that can agree with me. It's very regular. We can't see any P waves, and we can't see any retrograde P waves. So this is a narrow complex tachycardia, which is unlikely because the rate's not 150, so it's unlikely to be atrial flutter, and it don't see any signs of a sawtooth pattern. So we don't think it's atrial flutter. It's regular, so we don't think it's AF. So this is a narrow complex tachycardia, could be an AVRT, could be an AVNRT. And this is the sort of patient that we would do things like Valsalva maneuvers, carotid sinus massage, although bear in mind that you could cause a stroke doing that. So listen for a Brewy and just don't do it to a 90-year-old. So then moving on, we have our broad complex tachycardias. Now we're slightly running out of time. What time is it? We've got 10 minutes. That'll do, because I've not got a huge amount that I wanted to talk to you about broad complex tachycardias. So key points with the broad complex tachycardias is that there are two possibilities. One is that it could be a ventricular tachycardia, so the rhythm could be originating in the ventricle, and you've got broad QRSs because it's coming from the ventricle. The alternative is that it's starting in the top of the heart, and you've got aberrancy. So just as when you have left bundle branch block, you can have sinus rhythm with left bundle branch block, you could have a sinus tachycardia with bundle branch block. So it's aberrancy is what we use to refer to that. But bear in mind that the vast majority of broad complex tachycardias are due to VT. So if you see a broad complex tachycardia, you should be wary of diagnosing an SVT with aberrancy, because if you get it wrong, that's serious. If you just give a bit of beta blocker and go back to whatever else you were doing in the mess, then things can go badly wrong. And if they've got a history of cardiac issues, it's even more likely to be a VT. So if in doubt, treat a broad complex tachycardia as VT. In order to decide if it's an SVT with aberrancy, you're deciding first, is it left or right bundle branch block? Is it typical left or right bundle branch block? Now, your VT could be originating close to the bundle of His. So it could be originating close to the left or the right bundle, and that might be why it looks typical. So it doesn't guarantee you, but if it is typical, it raises the possibility that it's an SVT with aberrancy. And we can do things like Valsalva maneuvers. I'm nervous about doing carotid sinus massage, but yes, we could do that. Or we could give some adenosine to try and distinguish from an SVT versus a VT. If it's an SVT, we'll either get rid of it or we'll pause it. If it's a VT, usually it has no impact, although rarely VT can be adenosine responsive. So what does everybody make of this 12-lead ECG? Are you all very happy that this is a VT, or are you going to bravely tell me that this is an SVT with aberrancy? A profound silence on the chat. So I've got SVT coming through from Joseph, VT coming from Jenny. Excellent, a difference opinion. That's marvelous. It means that it's a difficult ECG, which is what I'm going for. So can you tell me, is this typical left bundle branch block? Because I think you've said left bundle branch block happily. Yes, it's we've got a V and an R, but is this typical? And the answer to that is yes. We have a deep V wave in V1. We've got a large R wave in V6. So this is typical left bundle branch block. So it's possible that this is an SVT, but you need to presume VT until proven otherwise. So this could be an SVT. What's the rate of this ECG? So can you see that if we look at the R waves here, it's basically two large squares between each R wave. So the rate is 150. So can anybody tell me what the SVT diagnosis is likely to be if this is an SVT? Because it's regular, so we're not going for atrial fibrillation here. Flutter. And can you see there is a sawtooth? Can we see our little sawtooths coming through regularly? So this is atrial flutter with 2-to-1 heart block. If you thought that was VT, then you've done as well as I would want you to do there, because that's the important thing. But this is actually atrial flutter with 2-to-1 heart block with the typical left bundle branch block. This is what the flutter wave should look like. This is an example of obviously someone with slow atrial flutter. In fact, I would worry a little bit about this, and I'll talk more about flutter when I talk about AF another time. But this is the regular flutter wave, which can you see you are still seeing this ECG with two of them between each QRS, so that we've got a flutter rate of about 300 and 2-to-1 block, causing a ventricular rate of 150 in the previous ECG. Now, VT is almost always regular. So unless it's polymorphic VT. So looking out for regular versus irregular VT is a very good help to you in deciding if it's VT or not. Irregular and typical right or left bundle branch block should be making you think atrial fibrillation. What about this ECG? Could this be typical or atypical? This could be a VT or an SVT with aberrancy. So this time round, is this right bundle branch block, isn't it? And is this typical or atypical right bundle branch block? So can you see little r, big R, RSR pattern? And we've got an S wave over here. So this is typical right bundle branch block. It's regular. We don't know if this is a VT or an SVT with aberrancy, but it could be an SVT with aberrancy, and that's what it turned out to be. But this could also have been VT. There's nothing that tells us that this is definitely not VT. So we could give some adenosine there to confirm the diagnosis. What about this one? VT, yes. So this, can you see this is an atypical bundle branch block? And so therefore it's highly likely to be VT. The other things that help us is, can you see there's extreme axis deviation? So it's actually positive in AVR. So it's pointing up towards the right, the signal's starting in the heart. It's going up towards your right arm raised up in the air. So that doesn't really make sense if the rhythm is originating in the atrium. So we've got profound axis deviation, and we've got very broad QRSs. Very broad QRS points towards it being a VT. And I think this is my last ECG. What about this one? Is this a SVT with aberrancy, or is this a VT? So Rebecca's asking what SVT with aberrancy means. So SVT, supraventricular tachycardia. You can call a narrow complex tachycardia an SVT, but the narrow complex tells you a bit more about it. So supraventricular, the rhythm is originating above the ventricle. So supraventricular, above the ventricle, aberrancy, it's broad complex, there's bundle branch block. The bundle branch block is aberrancy. So why don't we call it SVT with bundle branch block? It's too much of a mouthful, I suppose. So is this an SVT with bundle branch block, typical left or right, or is it a VT? Thank you for asking for that clarification, Rebecca. So can you see that there is quite nice narrow QRS? Can't possibly be a VT with a narrow QRS like that, can it? Is it typical or atypical right bundle branch block? Can you see an RSR pattern in V1 and an S wave in V6? So I think if you look, there is no RSR pattern, there's just an R. And the other thing, can you see these dirty great arrows that point towards things that look remarkably like P waves? And if you mark out your ECG and then ratchet that along, you then start to see, oh, these T waves are suddenly getting bigger because there happens to be a P wave superimposed on the T wave. So you can see that there are P waves and that they're dissociated from the ventricle. So sometimes you could say, oh, this is just a sinus tachycardia conducted through to the ventricle, but why isn't there one over here? Why is there no relationship between the two? It's because the atrium and the ventricle are doing two different things. That's AV dissociation, and that means that this has to be a VT because it's not coming from the atrium, because if it was, it would in some way reflect what the atrium is doing. So this is therefore definitely a VT, we can say with 100% certainty. We also look for things called fusion beats. That is, sometimes you get, this is an example of a capture beat. I'll explain this first. So if we have an atrial signal, sometimes there's enough of a gap between the VT that atrial signal can actually conduct through the AV node. It's not refractory, having just gone with a VT beat. And so we get a narrow complex in the midst of the VT. That tells us the other complexes are not being conducted through the AV node, and therefore it is a VT. Fusion beat is the same thing, but this signal fuses with a ventricular tachycardia beat. So we get a combination of the narrow and the VT beat. We get a fusion beat. And again, that tells us that this is VT. And here you can see some P waves, although not just before our fusion beat. You don't have to be able to see the P wave. You know it's there because the P wave will be going regularly at a rate of about 80 beats per minute here. And not reflecting the ventricle because the atrium's doing its own thing and the ventricle's doing its own thing. And one other ECG I want to show you is torsade de pointe, where it's corkscrewing round and round and round a point. And the very final one, this is the ECG you don't want to record. This is ventricular fibrillation. Wonderful. So thank you very much for listening. I hope you enjoyed that. I hope it made sense. It's nice to give these presentations in person so that we can explain things as we go along. It's often easier than trying to do it via the chat, but hope you found that good. I've recorded this, so I'll post it online for you. Please get your certificates. If you're having trouble getting them, I'm very happy to email them through to you. If anybody can tell me why some people are having problems and other people aren't, then that would be helpful. Please share this with your friends. The more the merrier. Very glad that people are listening in and finding it helpful. Take care.